Wayne, do you want to take me off as panelist?
Sure, I can do that. You're what we refer to as a vestigial panelist. Okay.
Or if you need help with questions, if anything happens, I can do backup.
Great, thanks, Debbie.
Thanks for being back, Debbie.
So
yeah, I got my computer updated, so I'm hoping the Zoom thing isn't an issue anymore.
Yay.
So all panelists that are not actively doing things will please mute and stop video, because we're about to start the meeting in a minute or two. We have participants joining, which is great. All right, my chronometer says it's time to begin. So let's get started. Good morning, everybody, and welcome to the Unitarian Universalist Congregation of Cleveland Sunday morning community forum. That's a mouthful. Today's forum is particularly interesting, involving a subject that's been on all of our minds for the last 6 to 8 months, which is the virus, COVID-19. And we have our speaker today, Amy Ray, and to introduce our speaker will be Laura Imbornoni. So Laura, why don't you go ahead and take it away?
Thank you, and good morning, everyone. Today's topic about COVID-19 couldn't be more relevant. With over 39 million cases globally, over 8 million cases in the United States, we now see surges throughout the globe. In Ohio alone, cases are surging up to over 2,000 new cases per day. It's causing tremendous stress, lifestyle changes, economic problems, major health problems. We all want to know what to expect for the future. I don't know about you. When I listen to the news reports about COVID-19, sometimes it's quite confusing to hear conflicting and different information from day to day. Do you wish you could just sit down with a knowledgeable doctor and ask some questions? If that's the case, you're not alone. We're very fortunate today to have Dr. Amy Ray for our COVID-19 topic. I'll say a few words about Dr. Ray and then she'll get started. Amy Ray, MD, MPH, is the medical director of the Infection Prevention Employee Health for the Metro Health System. As the recipient of the Barry Farr Award of the Society of Healthcare Epidemiology in 2018, Dr. Ray is a nationally recognized expert of infection prevention and healthcare epidemiology. Her national roles include service on National Quality Forum's Technical Advisory Committee and Quality Improvement Committee of the Infectious Diseases Society of America. Dr. Ray is an associate professor also at the Case Western School of Medicine, with more than 14 years leading infection prevention programs. Before she begins to speak, I want to add that audience questions and answers will begin around 10 o'clock. And now let's welcome Dr. Ray.
Thank you and good morning. It's a real privilege for me to be here with you this morning. And as I was preparing this talk, I am very reflective upon what Laura mentioned, in that all of us either directly and certainly indirectly, have been affected by this virus. And my aim today is to share with you where I think we are, where I think we're headed with the virus. I am here to myth bust, if you will, and be conversant with you. I welcome your questions in terms of which things I think we think are facts and which things are merely conjecture. And I'm hoping to point you towards some sources that you can rely upon for information and to help you navigate certainly what is reported in the lay press, which can be confusing at best probably, and nearly always overwhelming. But as I reflect upon this experience, I do want to just state to you, I am an apolitical pragmatist. So that has become important as we're doing more of these talks. We want to be scientific and reflective and not reactive. So having said that, let me make sure I can advance my slide. There we go. So I will start by discussing some current epidemiology. As Laura mentioned, the cases in Ohio are on the rise, and probably many of you are aware that Cuyahoga County made it as a transition back to a red county, which is the third level on the fourth of a public health awareness alert system. I will discuss and describe some common clinical observations and importantly, review modes of transmission and mitigation strategies. And then finally, we'll discuss the current landscape of treatment and vaccine development. And as I progress through the talk, I'm hoping that I can convey a sense of providing you the opportunity to think about this in a different way so that you can pull some silver linings and some lessons learned and from the content of the talk. So as I have, well, a little bit about me. I'm an infectious diseases doctor, as mentioned, and from very early in my medical training, my primary interest has been infection prevention and hospital epidemiology. And so I've been researching in this field and practicing this field, specifically the infection prevention piece, and leading it for a number of years, more than 20 now. And I was searching for a picture in my mind's eye to represent this pandemic. And I kept envisioning this, person or persons holding back something that is seemingly uncontrollable. And so I arrived at this, this artist's rendering of these horses being spooked and out of control. And while the kind gentleman, I'm sure, in his top hat is necessary, he's not sufficient to control these horses. So what can we do as an individual? And then what can we expect from our leaders as we progress through this pandemic? And at the moment, the things that we can do as individuals and the things that public health can do are limited to behavioral interventions. And so anytime we are limited to behavioral interventions, there is a, the sense of individual responsibility has to be then mirrored by the public health education of communities. And that process in and of itself takes time. So as we think about this virus, I would encourage us to qualify the virus as the enemy. So some non-pharmacological interventions that we've all learned about and heard about and practiced individually require a degree of grace, if you will. We have to be our best selves and set the example for those around us, because these interventions are actually effective. So what I will do a little bit later on in the talk is share with you what is the evidence for the things that we promote from a public health standpoint, and which of those things tend to be the most important. And then to contrast, so that list on the right-hand side of the screen are things that you can individually do, and certainly public health can support. But in addition, if we think about non-pharmacological interventions on the public health or hospital system side of things, certainly education is something that we are invest. We need to speak as much as we can to educate the public and to quiet down some of the hysteria that's in the lay press. But I would also put interventions such as testing of populations who may be at risk for advanced COVID-19. So use of testing, rapid identification of cases, contact tracing, quarantine and isolation of infected persons is very important, but those are still behavioral interventions at a community level. So my first takeaway point from this morning's time with you is to relay that all pandemics are local. So I think famously Tip O'Neill, who was the Speaker of the House, had a quote that said, he said, or at least he was credited with saying, all politics are local. And so all pandemics are local, and they do, as you've no doubt observed in the reporting in the media, it can be difficult to ascertain why New York City had such a terrible spring, and perhaps reflect why Los Angeles has ongoing high rates of cases, but milder rates of death. And so knowing what's happening in our own community and in our own surrounding counties is vitally important. So this data that I'm sharing with you reflects the state of our nation as of October 16th. This is a cumulative case count. And the case definition, though this can be a controversial point in the lay press, it's not controversial for epidemiologists such as myself, because for this disease state, we have a gold standard diagnostic test, which is a PCR, which is a genetic test looking for presence of the viral RNA. And so in the early days of the pandemic, that when testing was not widely available and the epidemiology was lesser known, there was a tendency, well, as with any pandemic, to look for risk factors coupled with clinical symptoms. So risk factors early on were travel to Wuhan City, and then more broadly travel to China. And then quickly it became apparent that this was indeed a pandemic, and the international travel piece became lesser importance when the virus is circulating within our own nation, state, and local communities. So this picture does show sort of the widespread nature of disease. There's been no state or territory untouched by COVID-19. And it's a snapshot. It's not comparative over time. It is cumulative. And certainly population density and the population at risk and lifestyle behaviors, and there are very many variables that play into or affect case counts, including, but not limited to, the availability of testing. So as a reminder, January 21st was the first case report in our United States. This is data that I look at almost daily. This is, again, publicly available data on the CDC website. And it shows, this is the number of COVID cases diagnosed per day. You can also, if you so chose, you can select for deaths. But you can see that as the case count climbed in the spring and when the shutdowns occurred, the case counts didn't substantially drop. They may have leveled at a lower rate, but there was there's no question that the shutdowns helped lower this rate. But then in the summer, what we saw was an increasing, I have taken to calling these wavelets, or maybe spikes is a better way of describing them, because I don't think we can really appreciate waves of a pandemic until the pandemic has indeed subsided. But in the through the summer, we had a lot of disease among young adults and adolescents, and more testing availability. And then unfortunately, as Laura mentioned as we started, our case counts are indeed increasing. So I give a fair number of talks, and I pulled some of my snapshots from prior lectures and various, given to various audiences, just because of this colorimetric comparison. This is looking at the state of Ohio, and you're probably familiar with the public health alert system. And suffice it to say that it's not a single number upon which these counties are designated their respective colors. These are indicators. There are 7 indicators that are analyzed by the Ohio Department of Health for each county. And if no indicators are met, or one may be met, the counties have low rates of infection, but active exposure and spread are still occurring. And so you can see that from September 3rd through the 17th and now into mid-October, we have a number of level 2 and 3 counties within the state of Ohio, which then should serve as an alert to us that widespread communication, or widespread transmission rather, of the virus is occurring. And as predicted, unfortunately, hospitalization rates are a lagging indicator, but as the community rates of incidence increase, the hospitalization rates soon follow in a week or 2. This is looking at hospitalization census across Cuyahoga County. This is data that I see daily, and it is a composite of all health care systems except for the VA Medical Center. And it shows that, in mid-July, we were in the county reporting about 250 cases hospitalized across the county. Then we had a nice steady decline as the local incidence of non-severe disease decreased. And then as schools have opened and colleges have opened, and also our weather has cooled as we come inside and spend more time indoors, following local increase in incidence is an increase in hospital stay. And so this is a slide that reflects the shutdowns of the 1918 pandemic. And what I include this slide because I think it's interesting just to remember that it does matter what we do locally. Not all city responses and county responses and state responses are created equal. And this was reflective. And so just some highlights, the things that most matter. So this tan bar is the duration of the shutdown in the various cities in 1918. And what has been known for a very long time is that if the death rate, which is the black line, if the death rate spikes sharply, if there's a delay in starting a shutdown, that will negatively impact the peak of that death spike, if you will. And then in addition to the flattening of the curve that we talked about through the spring was never intended to eliminate the virus from our presence. It was intended to minimize the damage at the highest level of that the virus can cause. And then if you have a short period of a shutdown so a longer periods with low rates, you may be able to avoid a second sort of higher spike. But Kansas City is the city that's very commonly discussed among infectious diseases geeks like me, in that they had a shutdown, but they didn't wait, and they reopened briefly to only realize, their rates of death are increasing. So if you open too soon, then let me see if I can find another. I think. One second, sorry. I was looking for St. Louis because St. Louis has a very nice example that is somewhat like this. If Oakland got down and then they had to shut down again. So getting rates under control in the local community does have long-ranging implications for how well the pandemic will go in your environment. So just a few words about the basics of this virus. This is an enveloped RNA virus, and it's the third in a family of beta coronaviruses that can have very severe outcomes. The incubation time is our way of saying if you've been exposed, if you become infected post-exposure, at what day and time does that most likely happen? And the range is between 2 and 14 days. But importantly, if you're exposed, what is the probability of actual infection occurring? And that is a number we refer to as an attack rate. So this is a very devilish, tricky virus because you can imagine if you look at this disease pyramid, if a virus only caused severe or fatal infections, that virus would be fairly easy to identify. And unfortunately, what happens with SARS-CoV-2 is that a large proportion, 80% or so, of infections are mild or asymptomatic. And that really confounds our response because instead of looking for the needle in the haystack, if you think about that, you're now looking, all the pieces of hay in that stack should be considered potentially infectious. And so that is the justification for horizontal interventions such as universal masking, social distancing, and the like. So the comparison with the sister viruses of SARS-CoV-2, so this case fatality rate is not fixed, it's not entirely known because it is a rate of death which includes a denominator of numbers of cases. And if we're under testing, it's easy to inflate the case fatality rate. But historically, what is known about SARS-CoV-1 is that the death mortality rate was 9.6%. But this disease pyramid looked very different, meaning it only had these top two tiers. No one who got SARS-CoV-1 had asymptomatic infection. And similarly with MERS, which is the Middle Eastern Respiratory Syndrome, the virus which causes that syndrome, the fatality rate overall was 35%. So these disease states were easier for public health authorities to identify because of how severely the patients presented for care. So this is just a very nice picture which relays that this is an RNA. Here's the virus. It has a nice envelope and it has these spike proteins. And the spike proteins are what enable the virus to attach to human cells. And this being a respiratory epithelial cell, and then enter the cell, replicate within the cell. So viruses are contingent upon their host for replication. And as a side effect of replication, they actually kill the cell. the cell breaks, it releases new virus, and then the body host response then can fight the virus and with its immune system, which in certain cases, including you may have heard about cytokine storm or or ARDS, which is a acute respiratory distress syndrome. The damage that's being done to the body is in response to the virus. So while there's cell death caused by viral infection, the host response, the human host response, is responsible for a lot of tissue damage, and therefore medications like the steroids we hear about are important adjunctive therapies for SARS-CoV-2. It's also relevant to note that many sites within the human body have a receptor cell for this virus. So the primary entry is indeed within the respiratory tract, but it's too soon to know how widespread, if widespread infection is occurring at these other sites, or if those sites that we hear about with kidney failure and heart involvement are being affected because of primarily respiratory failure. This is a very quick slide to highlight that in patients who have SARS-CoV-2 infection and they've developed COVID-19, which is the disease state, in the young and the not so young hospitalized patient population, cough is still the most common symptom that is reported, followed by any fever. But you will see that there are a laundry list here, if you will, of symptoms that can occur. But nausea by itself is very unlikely to represent a SARS-CoV-2 infection. So generally when patients present, they have one or two of the fever and cough, and it's not common for one symptom only to be present other than one of those two. But these lesser described symptoms are very similar to influenza. It is clinically not possible for me to differentiate influenza from SARS-CoV-2. So this is data from CDC, just quickly looking at the comorbidities which increase the risk of a moderate to severe SARS-CoV-2 infection and may lead to bad outcomes, including hospitalization and death. And I include this slide because it's striking to me that if we look at percentages of populations across the United States or the absolute numbers thereof, the prevalence of these conditions which predispose to severe disease is overall 41%. So if you think about having a viral infection that is new to our population at large, it's new to humankind, which means that we're all at risk for infection. We have no prior exposure or innate immunity. The sheer prevalence of these chronic conditions, it is not a difficult stretch to call this indeed the perfect storm. This has been shown time and time again in various sites that we consider it fact now that children are not likely to suffer severe infection. It's not that they never do, it's that it's very, very uncommon, and most of the time they have underlying comorbidities. So that's been replicated across many sites across the globe. As a reminder, this is typical seasonal influenza. The morbidity and mortality is always borne by the very young and the older advanced age population. This is seasonal flu. We in epidemiology call this the U curve of seasonal influenza. In 1918 pandemic, a lot of young healthy people died. We call this a W-shaped curve, and this I call a single-sided U curve. I've not heard anyone else that call it that. So this attack rate is if you are exposed to virus, and exposure has a definition. It has a definition for healthcare, has a definition in the community, which is in the community, more than 15 minutes within a 3 to 6 foot space of an actively infected patient. And so attack rate is very mitigatable. So And I will actually, given the shortness of our time together, I will cover that when I discuss the behavioral interventions in the next slide. But early on, it was not clear whether if you did in fact develop infection and were asymptomatic, could you transmit to another person? And the answer now has become clear that across this spectrum of asymptomatic to very severe cases, transmission does occur. The viral load, if you will, the amount of virus within a person's, the back of our throats, peaks about 24 to 36 hours prior to symptom onset. And then that high viral load is present for a number of days and then rapidly declines, and not many days, about 3 to 4 days, and then it drops off substantially. So this topic of modes of transmission has made it into the press, numerous times, and various scientists have presented strong arguments for airborne transmission. And so what I will say simply to you is this. This is a virus that if I were to actively suction an infected patient's airway, I may be able to aerosolize this. But it does not appear that routine transmission is occurring in an airborne dependent manner. And so what is not apparent in the literature for SARS-CoV-2 is that this person, if this lady is infected and she's speaking, singing, coughing, sneezing, she has large infectious droplets, and they fall, and just by virtue of gravity. If I were to suction her airway, I may be able to aerosolize smaller particles around her. But what has never been reported in the literature so far with SARS-CoV-2 is this long range over a long time. So these droplets that would stay suspended over the course of days, hours to days, and long ranges have not been described. So it's very important to be transparent and be very clear about, I think that what happens often is when the lay press says air transmission, yes, these are droplets that fall into the air, but airborne transmission has a very different implication for how we would manage a public health response. Occupational scientists purposely try to aerosolize virus because one case of a healthcare worker is unacceptable when they're doing that research. But preventing all infections is not a sustainable goal from an epidemiology standpoint. So we have to look at the most common mode of transmission, which is this droplet transmission. The virus does live on surfaces, but again, those studies are done with high amounts of virus intentionally contaminating surfaces. So how much of sort of touching things that are not, that are not human beings, if I'm touching my laptop after someone has sneezed on it, how much transmission is occurring in that setting is lesser known. And we know that influenza can transmit in that manner as well. It's certainly not the primary mode of transmission. I know we're running short on time, so I will just very quickly. This is a compilation of studies looking at these very dangerous viruses, MERS, SARS, and COVID-19. And so transmission is mitigatable by maintaining distance. So looking at confirmed infections, the further one was away from the source, the lower the rate of infection. So what does that mean pragmatically? It means that if you're 10% likely after an exposure to an infected patient, if you mitigate that exposure by just distancing. So if you were able to predict that you were going to be exposed and you avoided it by distancing, you reduce these odds from 1 in 10 to 1 in 50. And so this is the math behind social distancing. If you do not do this social distancing, you can see how this growth is exponential. Masking, again, this is a compilation of a large number of studies over a large course of time. And we know that masks are protective in healthcare. We refer to PPE as protective personal equipment. And most of the data in support of masking as protecting the wearer is from the healthcare environment. But there are some studies in non-healthcare settings. And so community masking, we know now, it's considered to be factual now that the masking of in a community setting, especially when indoors, especially when around others, that exposure that happens can be mitigated by the presence of a mask. It not only controls your secretions, masking may, in fact, reduce your risk of severe infection. And that is because if I protect my nose and mouth, and I unfortunately am exposed, perhaps in my eyes, as an example, instead of my eyes, mouth, nose all having a burden of viral infectious dose, if you will, the dose of the virus is lowered and the outcomes can be much more mild infection. So suffice it to say that it does matter what type of mask you're wearing in the community. This data is very lovely and I wish we had more time, but essentially an N95, this is a human talking with no mask on. And you can see this relative droplet count. This is a very elegant, the person is here talking, there's a camera and a beam of light captures these droplets as you're just speaking. And so if N95 contains secretions, surgical mask contains these secretions. Many types of cotton masks contain your secretions. What is notable, however, is that the bandana, which is why CDC, among others, do not recommend just pulling up a bandana because it's not very good at containing secretions. And then fleece apparently is very porous and is no different than actual no mask at all. And so I'm going to leave you with, this is my last slide. I probably could have made this slide the entire talk. This equation on the upper right is vitally important. So we have an entirely susceptible population. We have a very contagious virus and we have exposures, and that then leads to infection. So of these three variables, what can we control at the moment? We can control the exposure. So we're here along the spectrum. We cannot control the virus in terms of, we have no antiviral cure, if you will, but in order to decrease contagion, imagine a scenario in which we had early treatment of the SARS-CoV-2 infection with a rapid decrease in viral load. And so that would be the purpose of antivirals, to mitigate the risk of infection and transmission. And then susceptibility. So we need to get there by primary prevention, which is vaccine. The natural response to infection or herd immunity is not a good idea in terms of the amount of morbidity and mortality that we as a nation would incur if we rely on herd immunity. When I did the math a number of months ago, the number of deaths in that situation, by my math, would be 3.3 million. Vaccine safety is paramount. Clinical trials are ongoing. Probably you know that 4 are likely, more likely in the United States. There are a large number of candidate vaccines, but the 2 that are most promising are the Moderna and Pfizer messenger RNA vaccines. And I am going to stop there because I do want to make ample time for your questions. As you might expect, I can talk about this relatively endlessly. And so I will hush and listen.
Thank you so much, Dr. Ray. That was wonderful and informative. For questions and answers, you can do one of 2 things. Submit your question with the Q&A button, and Laura Imbernoni will field those. But if you have a complicated question and wish to ask it in person, use the raise hand button, and I will enable you to go live video and audio. So since there are none of those at the moment, let's go ahead and Laura, why don't you start passing on questions?
I will do that. And as you can imagine, there are a lot of questions for you, Dr. Ray. So let's see. There's there's a couple of questions about the vaccine. A personal question here. Will you personally take a COVID vaccine as soon as it's released? And along with that, what criteria should we use in deciding whether or not to take a vaccine?
So thank you very much. Great question. So, you know, what the criteria are the tried and true scientific methods looking at phase 3 clinical trial data, looking at effectiveness and tolerability of vaccines. So recently you may have heard that the manufacturers have reaffirmed their commitment to the science. And so I will follow recommendations from the ACIP Advisory Committee on Immunization Practices of CDC. And I do anticipate that, I'm hopeful that we'll have vaccine in a limited way by the end of this year, and very hopeful for 2021. The early data is looking quite promising. I will be receptive of vaccine personally. However, I will qualify that in that if the doses are limited, and they will be as we come out, we will prioritize them. The first tier, I believe, is healthcare personnel, and those are at higher risk for exposure. And I, in my administrative and mildly clinical role, am not providing, you know, the respiratory care that I kind of discussed in my talk. Once there are ample doses and we're all healthcare providers would qualify for vaccination, I absolutely will be the first in line.
Laura, we've got a hand raised questioner, Pat Dillard. Pat, go ahead and enable your audio and video.
Okay. I had a question about type 2 diabetes, and if it's well controlled by diet, is it still a risk factor?
So Pat, that's an excellent question. And it's a little bit too soon to know exactly how some of these comorbidities and the control thereof actually influence the risk. And the rationale behind that answer is that what is known at present at several months in, as you may be able to imagine, the data that has been reported regarding comorbidities is data from a hospitalized series of patients. And so it's not terribly reflective upon the spectrum of type 2 diabetics at ages 60 to 70 who may acquire infection. So those data are in process, but right now it's, first of all, I would encourage all of you, more control of comorbidities and including your dietarily controlled diabetes. Anything we can do to mitigate our own individual risk, be it compliance with antihypertensives or antihyperglycemics or activity and lifestyle management, it certainly has benefits beyond mitigating risk of severe SARS-CoV-2.
Thank you.
There are a number of questions about masks. So there's 2 or 3, and I'll start with this first one. When I'm out fast walking and jogging and no people are anywhere near, am I vulnerable to COVID-19 without a mask?
So I feel very safe saying that no, you are not vulnerable to COVID-19. And thank you so much for the person who asked that question, because this is what is lost in the media, and it's lost even with some in some surprising groups, in my opinion. In order for infection to occur, you have to have exposure. And exposure is person to person for more than several minutes of close interaction. So I am a walker, jogger as well, and I carry my mask in my pocket. Should I, pass someone on the trail, I am even though I think the risk is infinitesimally low, I may don the mask because it's become a matter of civility, in my opinion. But I don't think that an infinitesimal risk can be lowered much. I would encourage you to think about masking. This is a virus that really loves to cause this is a cluster epidemic. So anytime you can avoid a situation with a number of people together, that's when transmission is occurring. And I've interviewed many patients who come into the hospital and they've been on their best behavior for months, but then have a family get together for a July 4th because we're social, human beings are social. So I take a very balanced approach to the masking question. I'm very supportive of masking indoors when you're in the grocery store. I'm not judgmental about patients or persons who want to wear their mask in their car, even though that to me is just a matter of convenience. Perhaps they're more comfortable. And so I do know that these interventions of masking take time, and it's not at all surprising to me that it's politicized, because every infectious disease that's new has been, and the response has been politicized. So I strive to avoid that, and I strive to be gracious and not policing masking.
A couple of people wanted a little bit more information about masks. And I noticed right toward the end, you said something along the lines of, there are certain kinds of cotton masks that can be very helpful. So woven cotton, what kind of cotton mask is the most helpful? And there's some more along those lines. I guess basically, can you go into a little more detail about what is most helpful?
So most helpful is what you will actually wear. So certainly a single layer of cotton is not as protective as a dual layer. So I would avoid fleece, I would avoid bandanas, I would be supportive of a washable product and one that actually is comfortable. And more than one layer. But beyond that, the fit is probably somewhat important as well. You don't want to have big gaps. But essentially, you can't let the perfect be the enemy of the good. So even a simple, 2-ply cotton mask that's not waterproof is fine, and maybe as effective, at least with that data that I showed you, as a surgical mask.
What about some of the N95 we have available to us now? Are those especially potent in terms of protecting us? And can you clean those by hanging them in the sun for a few days and use them again? Or are they one-use products?
So I would not recommend N95 use in the community for a number of reasons. The first being those are respirators that have to be fitted to your face in order for them to be effective. So I would not want community persons to feel falsely reassured by a non-fitted N95. N95s are single use only, except in times of contingency or crisis, which we certainly are in those times these days. But N95s are the key to success in keeping our healthcare systems open and our healthcare workers protected. And so a lot of that early days of, first of all, there was an underappreciation of source control with the community wearing masks, and I'm very pleased to see that has evolved. But a lot of the early agitation was around the fact that N95s should be saved for those who will encounter the virus most frequently, and those are our healthcare workers. If you happen to have an N95, they cannot be washed. They will be destroyed, their fit will be impaired, and they're generally a single use.
So washing the cloth mask, that should be done after each use, and should you wash it in any special manner?
Warm soapy water. I throw mine in the just in the washing machine. So this is a virus that's really easy to kill on surfaces. So hot water soap, almost any hard surface disinfectant in your home is appropriate and will reduce the virus on your surfaces. No, so the mask cannot be microwaved. No, you need soap and water.
Okay, this next question about masks, I can't say I understand it completely, but I want to read it to you. I have a feeling it may speak to the controversy we've been hearing about masks themselves. Does a mask obstruct the exhalation of virus-laden breath, thus increasing the chance of sustained exposure to virus during inhalation? Do you understand that question?
So does a mask obstruct? Can you read it one more time, Laura?
Question may want to just come on live and ask it to be more clear if you want to do that too.
I think that person may be asking about masks or respirators that have an exhalation valve, which we don't recommend in the course of this pandemic, because if you happen to have infection, that exhalation valve is then expelling virus in a direct stream.
Nancy, you have a question.
Yeah, thanks for a great presentation. And I realize that your focus is the infectious disease that this is. But of course, many of the questions that are around about how to handle this also are looking at the mental health effects for people of isolation, and then particularly for young people with their both social isolation and the learning deficits that are going to come out of this. How does this discussion go with the infectious disease folks and those who are concerned about mental health?
So Nancy, it's a great question. And I usually start my talks by saying that I am an infectious disease doc, so I'm seeing things through an infectious disease lens. However, I am fully aware that suffering can occur in many different ways, including the mental health aspects of isolation and quarantine and lesser face time with professionals. I think that I have been very vocal from the early days about avoiding stigma and limiting patient care and mitigating transmission risks without, I think that unfortunately there is a tendency even in healthcare during shutdowns to say everything that's non-urgent needs to, and urgency in mental health may not be as visible as urgency of a ruptured appendix. So I think that the best I can do in answer to your question is I have been far more liberal than others in terms of identifying some opportunities to enhance visitation, for example, to really help us open our doors and remain so for those who are most in need. But I do think that history may not be very kind in this respect, both for mental health and for management of chronic comorbidities. There's clearly what we're seeing in the hospital are sicker patients as a result of, even from a medical standpoint, because patients didn't present early during the pandemic. Their underlying disease states have worsened, and the severity of illness has followed. And I fully appreciate that's likely happened on the mental health front as well.
Laura, we've got another in-person question. Pat Dillard.
Okay. My question is, well, it's really not a question, but I want to know what you think of this. My insurance company is starting a pilot project for prevention, and they're going to send out to me a package with Tamiflu in it, a thermometer, and a COVID-19 test, and a number to call in case I have any symptoms, and they'll tell me what to do. Have you heard of this? And it sounds like a wonderful idea to me.
I think that a more wonderful idea would be getting your influenza vaccine. It will be impossible to distinguish influenza infection from SARS-CoV-2 infection. And what we know about influenza is that if it can become resistant to Tamiflu. So I think that
they have asked us to get the flu, and of course I have the vaccine.
But I would be very curious and probably pretty critical of their indications for when to start Tamiflu, because I won't, as an ID doctor, I can't tell if your test that they sent you comes back in 5 days, it's not helpful, and you may miss a flu diagnosis. If their test is only testing for SARS-CoV-2, they may be under recognizing a truly treatable infectious disease, which is influenza. So I think it's well-meaning, but probably could use some infectious diseases input.
That's interesting. Thank you. Yeah, they said the issue was that if you take the Tamiflu within, I think, 24, 48 hours of symptoms, it makes it a lesser illness.
But if it's influenza, so Tamiflu has no biological effect on SARS-CoV-2.
No, the two different things, right?
And so self-starting Tamiflu is something that we've promoted in healthcare for a long time, but not in the setting of two dueling viruses. I think you would be best advised to start Tamiflu when advised by a positive test, because influenza tests are generally much more rapid and available. I do think that we risk under recognition of influenza this season. And so for that reason, a lot of the public health response is focused on SARS-CoV-2 and COVID-19, but we cannot miss circulating influenza. And if I cannot distinguish between influenza and SARS-CoV-2, no one on the insurance line can either, because they're not distinguishable. That list of symptoms that I showed you on the one slide, they're identical.
So you suggest going to your doctor right away?
I suggest giving your doctor a call right away and pursuing a test. Absolutely.
Okay, 100%. Thanks.
I'm not going to criticize starting Tamiflu, but 100% get tested, because the response is different. That your isolation would be different, your treatment would be different, and your risk, quite frankly, would be different because you've been vaccinated.
Okay, thanks.
There is a question about vaccines and sort of a comment as well. And the comment was, there are certain cultures and any number of individuals as well who are more fearful of vaccines than others. What are some good ways to help people get over the fear of vaccine for COVID-19?
So I think the best strategy is transparency. So transparency with the reporting of the data, transparency as the FDA has recently heightened again, or highlighted and heightened. It's the first step of any vaccine is understanding what you're trying to prevent, weighing the risk and benefit, and making sure it's safe. So I think that primary prevention in the form of immunization will be necessary, but not sufficient to get us to the end of the pandemic. So beyond transparency, I think that, you know, there's been an under recognition of vaccine preventable diseases because public health has done a good job at preventing those diseases historically. And so if you're in a younger generation and you've never diagnosed a case of measles or a case of chickenpox, you don't see the threat of the actual natural infection. So we're raising generations of folks who haven't seen those natural infections, and so they don't understand what they're preventing. And so so I think transparency and education are the keys, and presence and taking forums like this and answering questions, and as much as we're able to take the politicization of this off of the table. I think what in truth may happen is that once once healthcare personnel are immunized, the public may then follow suit. That certainly happened in H1N1 2009, where healthcare personnel were the first tier for that vaccine, and then the uptake within the population was fairly robust. But
a couple of questions that have to do with who is most likely to be infected if they're exposed, and if they're infected, who is most likely to develop serious consequences. One of them has to do with genetics. What role do genetics play in the development of COVID-19? Are some people more likely to be affected and have serious consequences than others? And also current health status. If you're healthy, are you less likely to be infected? If you have a bad cold, are you more likely to be infected? Can you address some of those questions?
okay, I'm going to try. That was a lot. So I will say that this is what I would love to highlight, which is we are all susceptible to COVID-19. So none of us have seen this in prior decades. We don't have innate immune response already built to against SARS-CoV-2. Now, so the population at risk. So people will say to me, well, Dr. Ray, we don't shut down, we don't have shutdowns when we see increased rates of, cardiovascular death. Well, we're not at all of us are not at risk for cardiovascular death at any given. We are at risk, all of us, for this infection. And so that's what changes your perspective. Once you realize that the threat is not just for, your neighbor or your, et cetera. So the risk of severe infection, or moderate to severe infection, certainly increases with age. That has been shown time and time again. If you add age plus a comorbidity, one or more comorbidities, your risk of having bad outcome, including the use of mechanical ventilation and hospital stay, mechanical ventilation, and death certainly increases. So whether or not a concomitant rhinovirus infection is a risk factor and would make one, quote, more susceptible to SARS-CoV infection is not known. It's not known to me if, a rhinovirus that causes a cold might beat out, if you will, like in a competitive way, a SARS-CoV-2 virus. And I'm not sure we'll ever perfectly know the answer to that question because of the sheer prevalence of the common cold. With regard to the genetic predisposition, I think that's very interesting and not yet fully understood, but certainly I think we're getting closer to knowing some, if, for example, those ACE2 receptors are expressed in different concentrations in different populations, be they ethnically or genetically or by age even, that remains to be seen.
Wayne, do we have any other live questioners?
No, we don't. We're, if you've got more Q&As, please continue.
And I see that we're coming close to the end of our time today. There are 2 or 3 questions that all come together. So perhaps we'll make this our last question. And I also want to cue my friend Pat Dillard that this is a good time to put something into chat here. So this last series of questions has to do with being out and about. What is safe? What is more safe? What is less safe? And so one of the questions is about going to a grocery store. Is it safe to go to a grocery store? And is it safe to use your credit card? What about the plastic shields that are worn by some clerks? Are those safe, or do they need to have a mask included? In terms of retail places, what is safe now and what is less safe?
Great questions. So I think when I consider such questions, you know, I encourage you to think about the basics of the behavioral strategy. So to me, you know, the risk of using your credit card and developing infection is probably infinitesimally to non-existently low. So what I do personally is keep some alcohol-based hand gel in my car so that my hands are clean, because it's our hands that auto-inoculate after handling our, you know, in theory could auto-inoculate after handling a credit card. But so the virus is not, it is stealthy in that can transmit from an asymptomatically infected person, but it's not very smart about, it needs that direct human to human interaction. So when I'm at the grocery store, I'm masked, and it's the same sort of principle, if you will, of what's the risk of a car accident and driving to the grocery store. So, you know, you can't eliminate that risk. The risk is not zero, but you do the things that get you where you need to be, which includes, you know, speed limits, speed limits, seat belts. It's been a very long several months for me, and airbags. You know, so you take advantage of all the tools that we have from a public health standpoint to keep you safe, but that's not a guarantee. And so there are no guarantees, but what has never been reported, to my knowledge, is an incidental transmission in a grocery store. So as long as you're not very closely talking to someone without a mask, you maintain the distance, you mitigate that risk. Remember what the data shows. If your risk is 10%, just by simply backing up and keeping your space, like a soccer coach would advise you to do, make space, you can reduce your risk from 1 in 10 to 1 in 50. So it's a game of odds, if you will. You need to avoid long durations of trips within, you know, a close environment. And so if that means you need to run into a retail store to pick up something, that's reasonable. But to hang out in a group of people shopping all day without wearing your mask is not reasonable.
Laura, do you think we have time for one more question from Nancy King?
I see that she does have a question, and I think this probably will be the last one, huh? There she is.
Okay, yeah. So my question is really about the what we're finding about effects post-COVID of some people with mental fog and others with harder lung or other things. What is the incidence of these problems for people who have had the disease perhaps very mildly or more severely? What's the incidence of post-COVID problems?
So that's a good question, Nancy. And, again, the data that we have are data of hospitalized patients and not those of mild infection. So I don't feel confident that we can give you a solid answer based upon a severely ill patient population. What I do feel confident in telling you is that every infectious disease has post-infectious complications. So it wasn't news to us from an ID perspective, because anytime you have end organ damage, you'll need time and or treatment to recover. So I do think that some of the post-COVID clinical syndromes are real, but I can't say that would be particularly, I don't suspect that with mild infection, a patient would have, prolonged post-COVID symptoms. I think it's more or less related, in my opinion, and again, COVID science is evolving literally by the second. But I think that most of the data now is from a selected population and is not reflective of the population at large.
Okay, thank you.
Thank you. And thank you, Dr. Ray, for this most excellent presentation. We especially appreciate you talking with us and answering questions today when we know you're enormously busy right now. Thank you so much, Dr. Ray. We have a couple of announcements, and one is about the chat box. And if you're using a PC, you'll probably find that at the bottom of the screen. If you're using a tablet or an iPhone, it may be near the top or on the side. And so the chat box can be used to leave us your email address, contact information, if you would like to be contacted or reminded of future forums. So please leave us your name and email address if that's the case. So next Sunday, October 25th, same time and place, we'll have 3 speakers joining us to talk about the frank talk on the protest movement. As we know, protests have been prevalent in our culture recently, and there's also a long, long history in the United States of protest. How effective are they in changing systemic racism or other issues? Are protests more compelling and effective than progressive legislation? We'll have with us Dr. Richard Perloff, a CSU professor of communication, Rachel Collier, organizer and program director of Ohio Student Association, and Melekte Meliku, ACLU Cleveland organizing strategist. This forum has been recorded and it will soon be available on the Unitarian website, uucleveland.org. The website's currently undergoing revision and it will be completed very soon.
One more quick note that in the chat conversation, Pat Dillard has posted a link to this morning's service. So it's a YouTube link. It's a link to a YouTube channel for this morning's UUCC service at 11 o'clock. So you can either copy that link. I think in many Zoom browsers, you can just click on it and it will go there, although it won't be active till 11 o'clock. So I suggest you copy that link and then paste it into your browser to link to YouTube to attend this morning's service.
Yes, Wayne, and the topic is very interesting. It's entitled Covenant is a Verb. We'll look back at 4,000 years of religious history and explore what it means to be in covenant, how we can currently become more peaceful and just by the use of covenant. The speakers include Dr. Alan Georgia and Mark Weber.
Great.
You all for joining us today. And we look forward to seeing you next week. And Wayne, I'll turn it back over to you.
Not much left, just to say thank you again to Dr. Ray and Laura, to you for handling the questions so well. And we'll look forward to seeing everybody next week. Thank you.